the next session. It's again a part of neurocritical care session. So another senior neurologist and expert in neurocritical care, Dr. Guruprasad, would be taking us through, and the interviewer is Dr. Sarala, who's again a consultant from Hyderabad. So the topic is on acute ischemic stroke, the concepts and controversies in management. Over to you, Guruprasad sir and Dr. Sarala.
Okay, good evening. So our topic of discussion now is acute ischemic stroke. So we all know that stroke causes significant disease burden and morbidity in the affected individuals, because of which more questions have been raised as to how we can better improve the patient management. To address these concepts and take us through the controversies in this topic, we have Dr. Guruprasad sir, a renowned neurologist. Welcome, sir. So we will start with the topic. So whenever there is a sudden loss of focal brain function, that is the core feature of the acute ischemic stroke. However, patients with conditions other than brain ischemia may also present in a similar fashion, that is nothing but a stroke mimic. So how to identify these various stroke mimics and how to differentiate from an acute ischemic stroke? Can you elaborate, sir, please?
Good evening, everyone. At the outset, I would like to thank CRITIC 2021 organizers, especially Dr. Srinivas and his team, for inviting me as the faculty for this conference, and I wish them all the best. So, if we look at the evolution of stroke management and evaluation, because now we are in an era of stroke thrombolysis. So the way we look at stroke mimic pre-thrombolytic therapy and post thrombolytic therapy, in a sense that in the era of thrombolysis, the time is essence. We call that as time is brain. So we don't have luxury of time where we can investigate and take our time to diagnose whether it's a true stroke or stroke mimic. So we need to investigate on the move, especially if they come within the window period of 4.5 hours, what we have now for IV thrombolysis, or if they're for mechanical thrombectomy, we need to do it very quickly. So there are certain things which we can keep it in mind. The history is so important in any conditions. History becomes very important. Someone comes with lethargy, altered sensorium, severe headaches, and the deficits doesn't match up with your objective. See, if you don't see objective loss of function, that means weakness or sensory loss, then you need to have that in mind that it could be something else. Or if you do basic investigations and if you see that the sugars are down. So one of the reasons you can have a stroke mimic is that encephalopathies, whether it is hypokalemic encephalopathy, hepatic, renal encephalopathy. So if you have a patient who already has a background of renal failure, hepatic failure, or diabetic with previous history of hypoglycemic episodes, then you need to rule out hypoglycemia. So they are one of the common causes. Then you can have a person who is walking to the OPD and progressive weakness on one side, which looks like a stroke. Then you can always evaluate, and imaging definitely gives you the clue. Tumors like glioma or meningioma can present like a thing, or in an elderly person, very trivial trauma can cause subdural, chronic subdural, and can also mimic stroke. Once you have the imaging and we correlate with the type of deficits a patient comes, then it becomes easier. So these are the common causes for stroke mimics. But the important thing is that you need to do it in a very quick time if they are within the window period. Then that's the challenge. And sometimes you can have a previous history of stroke and patient has a seizure. Like for example, a patient has a loss of consciousness, and when they're recovering from consciousness, they may have left with a deficit like a Todd's palsy. So again, imaging if you need to look at the images very carefully. The radiologist will tell you, but you also need to look at that whether that's the reason why looking at all the sequences of images. If you do an MRI, MRI mostly is likely to pick up any kind of other reasons for, I think, for example, MRI is normal and there's a deficit, definitely you can look at any other reasons. Or if there is a scar in the brain and the patient has a seizure and then is recovering, that's a Todd's palsy and you don't need to thrombolyze. So these are the situations, these are the causes for stroke mimics.
Yes, sir. The essence is that even if it is a stroke or stroke mimic, it is important that we catch hold of the stroke at the earliest. That is the thing.
Yes.
So as you correctly pointed out that we are in a reperfusion era, the immediate goal of reperfusion therapy for ischemic stroke is to restore the blood flow to the organs of the brain that are ischemic but not yet impacted. So starting from NIMS trial to IST3 trials, the conclusions and the current recommendations point towards 4.5 hours of window period. So can you please explain the concept of this window period versus intervention?
Right. So there is again the evolution of the thrombolysis over the last 20 years has been. So we have been witness to this. Where we have started doing IV thrombolysis, and now we have adequate data to show that mechanical thrombectomy definitely has a big role in reperfusion and then in the eventual stroke outcomes. So when we started with NINS trial way back in 1996, the trials were out, and then we started. I mean, India also began to thrombolyze quite early. 2000, when I was doing my MD in KEM hospital, we started very early to thrombolyze, and we come a long way. We have another agent apart from Altepase. We have tenecteplase now. Some results are coming. Some evidence is coming up to use tenecteplase. That is within the first 3 hours, whereas Altepase is now within the first 4.5 hours. But having said that, the trials, when they looked at subgroup analysis, they've shown that patients with a smaller stroke, where the NS stroke score is anywhere between 6 to 12 or 6 to 13, they are the ones who do well with IV thrombolysis. Someone who has a LVOT, what is large vessel occlusion, they are the ones who may not do well on IV thrombolysis. That's the reason why the evolution of thrombectomy came about. It went through a lot of things, because the ideal device, initially we started using suction devices, and then we used other devices. Now we have good devices. I think that makes the technological shift from the initial first generation devices to the present stent retrieval, that is the Solitaire or the congeners ones, are the ones who made a difference in terms of effective and simple use, effective use of things. So the ESCAPE trial, the cleanup trial, has now showed results that within the first 6 hours, if there is a LV, large vessel occlusion, you can look at, patient either bridging, or now there are trials which shown that even without bridging, even before, for example, you have a patient reaching the hospital within the first few hours, within the first 4.5 hours, where the patient is eligible for IV thrombolysis, but the patient has, large vessel occlusion. There are now studies showing that there is no inferiority of going straight away to mechanical thrombectomy as compared to the bridging therapy. That means IV followed by mechanical thrombectomy. So, but still evolution is, they're still evolving. We don't have perfect, evidence for that. We still practice bridging, where the patient is eligible for IV. We give IV and then take them to cath lab for mechanical thrombectomy. But that was up to 6 hours, the cleanup trial and the ESCAPE trial. Whereas now we have a DAWN trial and Diffuse 3 trial results, which shown that the window period now can be extended up to 24 hours. But with the caveat that there should be a clear imaging data showing that there is a mismatch, either MR-based mismatch, where there is a mismatch between a diffusion and a flare mismatch, or you have a CT perfusion mismatch. That means there is a significant amount of penumbra. That means some trials are used more than 15 ml of penumbra. Some have used 10 ml, more than 10 ml of penumbra. So that there must be good penumbra for you to go ahead and do mechanical thrombectomy in a MCA territory, anterior circulation stroke up to 24 hours. So it's not just a patient is above 6 hours of a window period and you go ahead and think. You should establish, because if there's a large infarct, there's no much penumbra to salvage. There's no role for mechanical thrombectomy. So you will end up with much more complications. Hemorrhagic conversion is more likely to happen if you don't take proper diligence. So you need to establish that there's a good penumbra, and then you can go ahead with, so there's something from time window, what we thought of, that is 4.5 hours, 6 hours. Now we have a tissue window where we look at penumbra. So we need to use imaging modalities to tell us that this patient is going to help by opening the vessel, achieving recanalization.
Thank you, sir, for clarifying it so well. So moving on to the next segment. So during acute management of ischemic stroke, the cerebral autoregulation is impaired. So the blood flow to the brain is dependent upon the systolic blood pressure. So if we decrease the blood pressure, there will be decrease in cerebral blood flow, and there is a chance that ischemic penumbra may be at risk of irreversible damage. And if we maintain very high blood pressure, there is always a risk of recurrent stroke. So how do we manage, and what are the blood pressure targets, especially with regards to before and after thrombolysis?
Right. So very important as an intensivist, I think your role of monitoring the patients is much more important, post, acute stroke. So we call 48 hours, up to 48 hours, the acute stroke period. That's the time when you need to, closely monitor the blood pressure and other, metabolic parameters within that range. So speaking about blood pressure, as we all know, it could be reactive, increasing blood pressure. Most of the strokes who come with large infarcts and all. If, for example, we need to look into all other aspects as well. If the patient is a known hypertensive, an average blood pressure has been high, then dropping the blood pressure too rapidly can also have issues. And also speaking about hemorrhagic stroke, also there is some evidence. It's a little controversial whether we need to get down the blood pressure very rapidly in a patient who has hemorrhagic stroke. That's a different topic altogether. Speaking about ischemic strokes, yes, for a patient who needs to be going for thrombolytic therapy, the target is around 180. The patient's blood pressure should be lower down below 108, 180, diastolic blood pressure 105. So around the map, around 110 up to 120 is quite okay to go ahead and thrombolyze. Usually we use labetalol. If you have enalaprilate, we can use enalaprilate. So the choice of antihypertensives is the center if they are comfortable with that, either labetalol or thing. We avoid using infusions, NTG infusions, for the fact that they should not be dropping blood pressure too rapidly. That can lead to more tissue damage. That means the ischemic area can get converted into infarct because there is an autoregulation. So we need to maintain that range of blood pressure thing. If there's a too rapid a flow, then you can have much more tissue damage. So important is to maintain MAP. Having said that, also important that it's not just post thrombolysis. Even after that, also if the patient, because understanding the stroke mechanism is very important. Someone who has a carotid artery disease or stenosis or intracranial stenosis, for example, if there is a patient having MCS stenosis. So what we have done by doing thrombectomy is that you're opening you're establishing the flow. But if there is a stenosis, narrowed vessel, which requires some intervention later or medical management, still there's a question of having hypoperfusion related worsening if the blood pressure is too low. So understanding the mechanism is very important. If someone has intracranial or extracranial stenosis, we need to maintain a MAP around 100, 110, not to get down the blood pressure, because we had instances where the patient has done well for 24, 48 hours. We restart their previous medications. There's a tendency that we start their medications and the blood pressure drops. That can worsen the clinical deficits. So you need to be careful that blood pressure is maintained in certain range till at least 5 days to 7 days. Once that acute period is gone, then you can be a little bit more relaxed and all.
Okay. So coming to intravenous thrombolysis, so current anticoagulant use and also evidence of anticoagulant effect, by example, by laboratory parameters, is a definitive contraindication for intravenous thrombolysis. But presently there is accumulating evidence suggesting that recent use of direct oral anticoagulants with the probably inadequate reversal is not associated with an increased risk of intracerebral hemorrhage following the thrombolysis. What is your opinion about that, sir?
No, someone who's on warfarin and acetrom, INR, some centers, some studies have shown less than 1.8 or 1.6. If the INR is 1.6 or below 1.8, there's no patient can, we can go ahead and thrombolyze. Someone who's on newer anticoagulant, either dabigatran or rivaroxaban, apixaban, if they are not taken before the last 48 hours, if they are not received before 48 hours, then they still can go ahead with the normal renal functions. If they're abnormal renal functions, then more so at least a week we need to see that they have not taken this NOAC. Reversal, I'm not sure, but these people can be considered for mechanical thrombectomy rather than IV thrombolysis, unless they have a small vessel disease and thing. Then the use of IV will be much more riskier as compared to managing conservatively. So I would advise this: if these parameters are looked into, then we can manage them that way.
So if the INR is in the target range and if they have not received within 48 hours, maybe
40 hours is for NOAC.
No,
For patients who are on dabigatran or rivaroxaban or apexaban, the newer anticoagulants, they need to be not taken their anticoagulant drug for the previous 40 hours. Someone who's on acetrom or warfarin, if the INR is less than 1.6, then there's no problem. They can go ahead and thrombolyze.
Okay,
because for people who are on newer anticoagulant, PTINR is not the test.
Yes, definitely.
So factor XA, 10A, all that is done, but that takes time. That's not easily available. So we don't have a marker for that to decide whether he is adequately anticoagulated or not. So question comes whether it's taken the medication or not. If you are sure that it's not taken for last 2-3 days, then we can go and thrombolyze. If not, then we can't thrombolyze. Reversal, I'm not sure how it works, because again that can cause more thrombotic issues. So I would be very careful with that. I would probably look at large vessel. If there is a large vessel occlusion, straight away go for mechanical thrombectomy.
Okay, sir. So moving ahead, as you have correctly mentioned, the time is brain, and alteplase is an approved therapy for acute ischemic stroke, and there is a substantial evidence about its safety and also efficacy. What if the patient is not in a condition to give consent and if the surrogate is not available? How to go forward with regards to reperfusion therapies?
Yeah, it's a challenge. Basically, what we've seen now, it's become a standard of care. Unless there's a cost issue, they usually don't refuse. In my experience, they usually don't refuse. If you explain to them, the condition and what difference does it make, definitely the consent, is usually given. But that's what. So if they are within the window period and they don't agree for either IV thrombolysis, or if there's a large vessel occlusion and if they don't agree for mechanical thrombectomy as well, then I don't think you have any choice. Then manage them conservatively. We can start on antithrombotic. There's a role for loading dose of clopidogrel and followed by dual antiplatelets for 21 days. And if there is no major extracranial or intracranial stenosis after 21 days, you can switch over to single antiplatelet. I would prefer clopidogrel because it's much more potent, but studies have shown ecosprin is good enough. 75 milligrams daily can be enough, unless they have significant intracranial stenosis or extracranial atherosclerosis. Then you need dual antiplatelet for a longer time. There's no role for anticoagulation in acute or chronic unless they have cardioembolic source. Either there is a dissection of vertebral artery or carotid vessels, or there is atrial fibrillation. So these are the only indications which we use anticoagulation these days in acute stroke setting. Otherwise, there's no role for anticoagulation.
So if the surrogate is not available to give consent in the best interest of the patients, can we go ahead and thrombolyze?
Yes, because studies, the American Heart Association organization like that has said it's an informed consent. They don't even push for a written consent. Unless they're going for a mechanical thrombectomy, because it's a procedure. This is a medication. So well-informed consent is good enough. But if each institution can have their own thing, if they have a proper written consent form, it would be better to use that. If not so, then if you can document in your notes that spoken to the family, they've understood. I understand if the patient is, say can't understand, if the patient is aphasic, what would you do? Probably you can call them relatives. If they're on their way, we can talk to them. Or if any caregiver, we can explain to them. I think that should be. I think well-informed consent should be good enough.
Okay, thank you. So going ahead, regarding role of imaging, like patients with suspected acute stroke should get emergency brain imaging on arrival to the hospital. Should be done. And CT is effective to exclude hemorrhage before antiplaque administration. And also MRI is useful, especially in wake-up strokes, to differentiate between the diffusion positive and plain negative lesions. We can go ahead and give the patient might benefit from antiplaques. So what is the role of MR angiography or CT angiography, especially with regards to deciding on intravenous thrombolysis and thrombectomy? Can you elaborate on that?
Yeah. So imaging is the cornerstone. So either you use MR-based protocol or CT-based protocol. Each center have their own protocols. Depends on their workforce. If they have a heavy load, when they have a large volume of stroke patients, and they have a fellowship program, postgraduates round the clock, they would be happy to do a CT-based thing. In my center, we use MRI-based because we depend on emergency physicians, intensivists. So we are comfortable having, like for example, we spoke on stroke mimic. So MR will, within an hour of onset of stroke, MR will pick up any kind of ischemia, even if it's a lacunar infarct. Brainstem, sometimes it can be a little delayed, maybe a few hours, but most of the times MR picks up. So having said that, a lot of studies have shown that if you have a thrombolytic therapy for stroke mimics also sometimes, the complication rate is very minimal. So I don't think that should be a reason for not to thrombolyze if they are within the window period. So MR that way is useful. CT is very quick. You don't need any cooperation from the patient side. It can be done in less than a minute. And apart from looking at the parenchyma, because we need to do aspect score, what is the extent of the infarct in the brain on CT, because MR in MR very visible whether it is less than 1/3, more than 1/3 of MCA territory. It's very easy to read, even a person, because it's visually appealing. Whereas CT sometimes we need to adjust the resolution to see is there any, if it's very early infarct. Apart from having a look at the parenchyma, we need to look at the vessels, because angio, one thing is important, either is MR angio or CT angio. As I said, if there is a large artery occlusion up to M2, carotid, be it carotid vessel or MCA or ACA, up to A1, A2 or M1, MCA up to M2, we can still do mechanical thrombectomy. Earlier days we used to do intraarterial thrombolysis, but nowadays we don't use much of intraarterial thrombolysis. That means injecting the TPA inside the vessel. That is now done very few times, when after doing mechanical thrombectomy, if there is a risk of distal embolization, we sometimes inject TPA after doing the thrombectomy. Otherwise, we don't use. Earlier days, we used to use thing. So angio is very important to look at, is there any major artery occlusion, whether it is extracranial or intracranial. Even for posterior circulation also, because basilar artery thrombosis can be, thrombectomy can be done for vertebral artery or basilar artery also. So, and there is an extended window period for posterior circulation. So vessels give us that answer, whether there is any large vessel or no. That's important. And also CT angio is important because it also looks at collateral circulation. The collateral circulation gives us, significant amount of prognostic value. The better the collateral circulation, there's a higher chance of recannulation. The outcomes are better. If there is the collateral circulation is very poor, the chance of hemorrhagic conversion is very high. The chances of patient's outcome being good is unlikely. So collateral circulation is given in the CT angio as compared to MR angio. So there are advantages, there are disadvantages, but again it depends on the center which uses that. Coming to another advanced thing is the perfusion scan. So when you have we don't need to do upfront. Sometimes if there is a very small area on the CT where you can't pick up on the routine CT scan. For example, a stroke mimic and all, perfusion scan gives us the answer that whether there's a ischemia or not. But that's a very small indication. But perfusion is used basically to look at whether there is a penumbra, significant penumbra or not. So we look at three parameters. One is cerebral blood flow, there is cerebral blood volume, and something called MTT, or we call this Tmax, the peak maximum peak time to reach the peak time. So these are the parameters we looked at perfusion, and that gives us one thing is the quantity of the penumbra. So depending on that, we can look at whether we need to go ahead in the extended window period. Within the first 6 hours, some centers use that parameters also within the first window period, because if there is already at the onset, if you have a large infarct, there's no penumbra to be opened, then sometimes talking to the family and all, we say that it may not work well. We just observe. That also can, some of the centers we do. But given the standard of care and all, we still can go ahead with IV thrombolysis. So looking at the parenchyma, vessels, and the perfusion gives us a lot of information which we can use it in different stages of acute stroke.
Thank you. So, as we know now that for eligible patients with the stroke, IV antiplase is the first line provided the treatment is initiated within 4.5 hours. So, the treatment with antiplase is definitely time dependent. Whereas mechanical thrombectomy is indicated, as you said, due to a large artery occlusion. So, what are the benefits and risks of thrombectomy for patients who are not eligible for TPA? What can we expect from there?
That's what. So basically, if someone who has good collateral circulation, good penumbra beyond 6 hours, within the first 6 hours also we can use the same parameters. But even if the penumbra is small with the first 6 hours, because of the time window, we can go ahead and think. But beyond 6 hours, up to 24 hours in anterior circulation, we can look at this tissue window. That means using the help of perfusion, either MR perfusion studies or CT perfusion studies, or mismatch, like clinical and imaging mismatch. For example, the patient has significant deficits, like an score is around above 15, up to 20, 22, and the imaging doesn't show so much of deficits. So if there's a clinical imaging mismatch, or in the imaging itself you have a mismatch, and then you have perfusion showing good amount of penumbra, up to 24 hours, we can still go ahead and do the mechanical thrombectomy. But see, it's not like you have that 24 hours, you should use that luxury. Every minute counts. I think everything has to be done in a quick phase, because the decision making has to be fast. Because every time you miss 1 hour, delay 1 hour, then that much neurons are damaged, then the outcome will be poor, and then they will have, and the edema, cerebral edema is all related to the extent of the infarct. So we should not be wasting time, even if we have a window that much, but that's only for that much we can do that within that hour. But it's not be that we can still wait till 24 hours and do the things in the last hour. It's not like that. Even within the first 4.5 hours of the IV thrombolysis, studies have shown that the patients who underwent thrombolysis, IV thrombolysis in the first 1 hour are the ones who have the maximum advantage. So every minute counts, and you need to do it quickly, either mechanical or IV.
So yes, so mechanical thrombectomy is indicated for patients who can be treated within 24 hours from the last.
For the anterior circulation,
to be well, yes.
For the anterior circulation, for the posterior circulation can be still extended. Sometimes you've done beyond 24 hours also. But right now, the evidence, the trials, the diffuse and the dawn trial is only up to 24 hours.
So beyond 24 hours, the posterior circulation can.
Bacillary thrombosis, if the infarct, if there's a mismatch and there's a thrombus in the bacillary artery, we can still go ahead and retrieve the clot.
Okay. So coming to the complications, treatment with IV antiplase is associated with sometimes hemorrhagic transformation. It could be as high as 5 to 7%. So how do we predict this hemorrhagic transformation in the stroke, and how do we manage that?
So 2-3 things. If the size of the infarct is bigger, more than 1/3, then there is a higher risk of hemorrhagic conversion. If because the involvement of the gray matter is more, and the vasculature and thing is much more, the autoregulation is much more affected in the gray area as compared to the white matter. The chance of bleed will be more there. A lot of blood pressure fluctuations. If the blood pressure is not monitored and managed well post thrombolysis, then there is a risk of hemorrhagic conversion. And other thing is the collateral circulation. So when we do a CT angio and you see that the collaterals are not good, they are the ones who have a higher risk of hemorrhagic conversion. So as you said, it's almost 6%. The symptomatic is less than 1%. Then the age also matters, and hyperglycemia is also one of the risk factors. during the acute 24 hours to 48 hours, if the sugars are not well controlled during the first 24 hours, they are the ones who also have a higher risk of hemorrhagic conversion.
Thank you, sir. So having discussed the acute management of the stroke, for secondary stroke prevention, how do we decide on how to use, like whether it is a single antiplatelet or double antiplatelet drugs, or how much duration should we use, or if at all the anticoagulation is indicated for any other reason, when to start and for how long should it be given? Can you throw more light on this?
Yeah, I think I'm answering your previous question. I had answered that. So the earlier we used to overlap with cardiology. I think patients who had coronary artery disease, we used to use the same data and use dual antiplatelets. But now we have a lot of trials which shown that as compared to dual antiplatelets, single antiplatelet, the risk of bleed is much more in dual antiplatelets in patients who had stroke. So single antiplatelet is good enough for secondary prevention, unless, as I said, if there is a significant intracranial disease or extracranial disease, you have a significant amount of carotid disease or vertebral artery disease, then you require long-term dual antiplatelets, maybe 6 months, 1 year, and then repeat the Doppler and then see if the disease, and use high-dose statin. And once the disease is better, then you can probably change out to thing. Or otherwise, usually the first 21 days we use dual antiplatelets. You load with clopidogrel 300 mg, and then followed by 75 milligrams daily, along with aspirin 75 milligrams. After 21 days, you can switch out to single antiplatelet. That's the usual standard of care for patients who don't have significant disease vessels. There's no stenosis in your angiogram, either MR angio or CT angio. You don't have disease things. Talking about anticoagulation, as I said, only 3 indications for anticoagulation in acute stroke setting. One is a dissection of a vessel, either vertebral or basilar or carotid artery dissection. We use for first 3 months to 6 months. Again, you can follow it up and then see if there's a thrombus and the false lumen has been resolved and the flow is restored, the stenosis is not more anymore. Then you can switch over to antiplatelets, antithrombotic therapy. Atrial fibrillation, low atrial fibrillation requires a lifelong anticoagulation. Either if there is no valvular disease, low atrial fibrillation, there is role for NOAC, newer anticoagulant. But in someone who's not, wanting to use NOAC, then acetram, the age-old acetram and warfarin with a good INR monitoring can be used for long term. Cardioembolic, again, depends on various things. For example, valvular disease requires, with atrial fibrillation, requires long term. If there's a LV clot and, there is a cardioembolic stroke related to that, we can always look at 6 months to 1 year of anticoagulation and keep looking at that. And in consultation with the cardiologist, you can decide how long you need to continue anticoagulation and then followed by antiplatelets.
Thank you, sir. I think we have reached our time. Thank you for the elucidative explanation of the concepts and also resolving the controversies in acute ischemic stroke. Thank you very much for your time, sir.
Thank you, Dr. Sarala. Thank you.